Welcome everyone. My name is Richard Hardwick. I'm the Medical Director at Sighted Health. If any of you don't know who Ian Penman is, you're probably in the wrong meeting. But it is with great pleasure that we have Ian to talk to us. Previous Vice President of the BSG, had the BSG Presidential Medal, has worked a lot on Barrett's esophagus over the years, and after the COVID pandemic with the Cytoscott team, really embraced a solution to a problem that every endoscopy department was facing, which is how are we going to manage this? And Capsule sponge became very much part of their whole approach. If Ian was a stick of Brighton rock, he'd have BSG all the way through the middle of him. So he's come off the 18th green in semi-retirement to come and talk to us today about the Lothian experience of using Capsule sponge in surveillance of Barrett's esophagus. Thank you, Ian.
Thanks very much, Richard. So I had originally hoped that I would be talking to you today about what the new BSG Barrett's guidance would be saying and give you insights to what was about to come out. The guidance has been done to update from the last BSG guidelines on Barrett's, which were 2013-14. They've just been held up a little bit by, with BSC governance processes, but I'd hope they'll be published soon. So I can't really say much about that just now because they're not official. And so what we're going to do is talk about how we rolled out Capsule sponge for Barrett surveillance in Lothian. These obviously are my conflicts of declarations. I have to show this because it's about the only photo of the Royal Infirmary on a sunny day. And it's taken from far up on a drone, so you can't see that it's made of tin and plasterboard. But that's where I work. And I'm keen to point out, these are what you're going to hear are my personal views. I'm not here representing NHS Lothian, and I'm not here representing the BSG. So where did this all come from? Well, if I go back to 2017 to 2019, even though I'm a sort of clinical Barrett's specialist, among one or two other sort of interests of mine, even though I thought we had quite a well-organized Barrett service in Lothian, by that I mean that following the 2013 guidelines, we had set down an SOP, this standard operating procedure. This is how we'll manage Barrett's in Lothian. We had a flow chart. It was circulated. I did education. I did in-house. I did training. We had protected Barrett slots. We had upskilling. We had a system on our electronic patient record, our track order comm screen for specifically for Barrett's cases, so we could pull them out and identify them. And yet we were probably 2 years behind with Barrett surveillance. So people who were due in 2016 were not getting it done till 2018. And I used to, as Peter Cotton once said, if you're not waking up in the night sweating about it, then, you know, there's a problem. And I used to wake up in the night worried about what on earth is going on here. And that was then compounded by the onset of the COVID-19 pandemic, when non-emergency, non-therapeutic endoscopy stopped briefly, and because of all of that, and we fell even further behind. And to great credit to Scottish Government Health Department, they rapidly got together and under, I think, the leadership of Grant Fullerton, an upper GI surgeon with a great interest in Barrett's, who was a part-time sort of government advisor. And Scottish Government Health Department worked really hard to bring us all together under a Once for Scotland programme. So one set of documentation, business case, SBAR, risk analysis, DPIA, all of that put in, approved, and then that could just be taken by each of the 14 health boards and move forward. We didn't have to repeat the whole process again. And I think that is a great innovation that should stay. So we did that, And that was also done in a very good collaboration with SciTed and, as it was then, with Medtronic to provide a managed service so they would supply the capsules, Cytosponge as was, and then the centralized reporting service provided by SciTed and back again. And they also provided great support to train up nurses to deliver the service properly, so that the last thing you need is tests not being done to a high standard, and with audit. And Scottish Government actually funded one of our junior trainees, a young girl, Siobhan Chen, lovely trainee surgeon, to be the sort of Scottish-wide research fellow come data gopher. And Siobhan ran around the country gathering everybody's data and inputting it into a central database on a server held by Public Health Scotland. So it's all encrypted, GDPR's followed, all the data is high quality, and it is not sitting on Ian Penman's USB stick that he left on a train. So that's where we were. So let's just scan back a bit. I work in Edinburgh. Edinburgh Royal hosts the regional upper GI esophagogastric MDT, covering a population of about 1.2 million roughly, over quite a big geographical area, as far down as Dumfries and Stranraer and up into North Fife. And I've been a member of that MDT since 1998. You can see here when I had hair. This is how long ago this photo was. You were allowed to wear a watch in endoscopy without being shouted at. And my boss and mentor, Kel Palmer, still wore a tie and a white coat. And I've been going to that MDT for 28 years now, and it's the same story every week, isn't it? Can I just do a quick straw poll? Who goes to an esophagogastric MDT? And isn't it the same thing? 68-year-old man with dysphagia, bulky Barrett's cancer, T3N1. Kel Palmer used to come in when I was doing my endoscopic ultrasound, and I just started. I'd come back from America, and we'd set up endoscopic ultrasound. We staged esophageal cancer with it. And he'd come in and he'd walk through the suite. I'm busy doing it. And he'd walk in dressed like this. And he'd look at this fuzzy grey and white screen and he'd go, T3N1. And I said, how do you know? He said, it always is. And we do heroic things for these patients, and you know how it's going to play out. And they pass away. And although there is a hint that 5-year survival is getting slightly better, it's still somewhere between 15 and 20% for all comers presenting symptomatically. And that's exactly how it was when I first became a consultant. And so part of my thinking was, I'm the Barrett's lead locally. I'm fed up that we have, despite running around on the hamster wheel, we have not really made incremental progress in looking after people with this horrific disease in the space of my entire consultant career. So quite obviously was, how do we get from this to this? So that's step one of the thinking. And step two was, well, along comes Capsule Sponge. Rebecca and the team in Cambridge have been working on this for a decade or more in a stepwise, incremental, evidence-based, scientific approach. If you were at her tour de force plenary lecture today, then there's nothing really I can tell you that you haven't heard from an even better source already. And so this was not a flash in the pan, let's just panic and go to the local shop and grab something off the shelf and try it out and see if it works. It was, I think, again, my personal opinion, pretty much ready for prime time, but we were moving very slowly through the regulatory gears. Rebecca touched very briefly on the BOSS trial, and we could have the whole afternoon talking about the BOSS trial today, suggesting that, Barrett surveillance isn't very good. And it would be true to say there is a lack of strong evidence for endoscopic benefit at the moment. But it's an invasive, expensive, laborious, unpleasant test. We're all told we've got to do surveillance under, well, not surveillance, but upper endoscopy under throat spray. Who does C10, M10 Barrett surveillance under throat spray? We all do. People thrash around and we think we're doing a good job, but we're trying to, So that's the next incentive to try and do something differently. This was our flow chart that I developed in 2013-14, and we updated every couple of years and circulated around how we're meant to manage Barrett's in our region. And all we've done is add on that this bit down here, once people have been through, we've confirmed they've definitely got Barrett's. The index procedure has been good quality, using proper documentation, good photography, good tolerance, adequate biopsies taken. That's all reviewed. And then once they get into Barrett surveillance program, which begins, we took a decision about 10 years ago that once people are found to have Barrett's at an index symptom-based endoscopy, they would have a repeat procedure within a year to establish ground zero. And then they go into surveillance, rather than complains of reflux and dysphagia, gets a throat spray diagnostic upper, suspicion of Barrett's, few biopsies taken, yes sir, these confirmed Barrett's, we'll see you in 3 years. So we've been doing that for a long time. And so we simply moved that to cytology sponge. That's not cytology, capsule sponge, sorry for the typo there. One of the arguments that always comes back is, yeah, but I mean, endoscopy is the gold standard and you haven't got randomized trial data to support this move. I know the pandemic's over now, Ian, we should go back to doing endoscopy. And you say, well, we have a good amount of data. Professor Fitzgerald went through it earlier in her lecture to support the accuracy and utility of capsule sponge in Barrett's. But you've got to remember there's a difference between the gold standard, namely an endoscopy done by Professor Bandari or by Massi Di Pietro, a true UK tertiary Barrett's expert, and your average Barrett's endoscopy done anywhere around the UK on a busy mixed list, perhaps by somebody for whom Barrett's isn't the reason they get out of bed in the morning, and we have good evidence for this, that it is not a great gold standard as currently practiced. And it's not UK evidence, it's international evidence. This is from the States, suggesting that when you put Barrett's cases to 275 gastroenterologists and you measure how they would manage it according to guidelines and international best practice, they're all over the shop. They don't follow their own guidelines. We also know from other studies that certain groups of patients are disadvantaged and really struggle to access healthcare, and that there are racial, socioeconomic, age and gender issues part of that. And part of it relates to the invasiveness and availability and access to endoscopy. We've got data from the Nordbest study showing that quite a lot of esophageal adenocarcinoma is diagnosed within a year of an upper endoscopy in Barrett's that didn't find cancer. And that just like in the colon, endoscopists with a higher neoplasia detection rate in Barrett's surveillance have a linear lower risk of post-endoscopy Barrett's neoplasia. The longer you look, the more care you take, the better you are at finding subtle abnormalities, the lower your risk of having a patient come back in the next 3 years with a Barrett's cancer. None of this is earth-shattering. Said another way, about 2/3 of patients with dysplasia on biopsies, but no visible lesion, who get referred into a tertiary centre, have a lesion when an expert looks. And about half of people referred to an expert centre with high-grade dysplasia are found to have a lesion. And a significant proportion with low-grade dysplasia are upgraded when they're reviewed at an expert centre. So a lot of breast beating and rending of garments over why we're actually not making much of a dent, despite peddling furiously. We're just doing the wrong thing, or we're doing the right thing, but doing it badly. And lastly, Nigel Trudgill's work on Pugic. And we know that having Barrett's is a major risk factor for a post-endoscopy upper GI cancer. And here is an 80-year-old man, coffee ground vomiting. He's brought into the ward. He's stuck on the next morning's endoscopy list, done by, very nice chap, very good physician, hepatologist, who says, oh, there's a hiatus hernia and there's C1M2, which I was quite impressed with for a transplant hepatologist. That's good. And an area of granular tissue, maybe a healing Mallory Weiss tear. Sent him back to the ward, high-dose PPI, and thankfully he came back about a month later or 6 weeks later for a check endoscopy, but he has an obvious cancer. So, what did we do? But on to the real subject. So that's the background as to why I felt we needed to do something different. We needed to shift the paradigm. So we put in our own business case. We did an S-bar. We put it into, at the time, remember, this is during COVID when every trust unit, chief exec and the medical director, there's a sort of gold command unit who rapidly look at everything and rubber stamped it and said, yeah, go ahead. And I said, what, really? And we developed a detailed SOP. We made new hospital referral guidance pathways, put them all on our intranet, modified the electronic patient order comm screens, set this up at 3 centres. Cited and Medtronic were extremely good at sending, I can't remember who the nice nurses were who came up from Cambridge to do our training, but they were fantastic. Great training for some of our staff. And we started top down. We thought, right, well, since a couple of our nurse endoscopists can't scope now because it's COVID, we'll get them to lead this. And Sarah Douglas, our very senior clinical physiologist who's done all our esophageal physiology for many, many years, and our Capsule service. And these were the 3 core people that actually delivered the service. And we allocated a couple of people in our endoscopy bookings team and admin team to do all the sort of paperwork for this. I'm not going to walk you through, but this is a sort of a summary of the SOP, and I think this is critical. This is actually outlining every step of the process. Who identifies the patients, who contacts the patients, who books the patients, who sends the sample away, who gets the sample back, who uploads the results. So there have to be named people against this with clear criteria as to what their responsibilities are, so that there are no holes in the cheese that could all line up and hurt. Obviously, we have moved in Lothian in the last couple of years over to Endosign. We are a training centre. We have upskilled and trained 3 Band 5 nurses, 3 Band 6 nurses. These are our endoscopy staff who do this. One of our nurse endoscopists does it. And when I call them clinical fellows, one of them is a specialty doctor in training, and one is a sort of junior clinical fellow. And they are overseen by Sarah, our Band 8 physiologist, and myself. So we are the sort of arbiters. If there's any problems, they come to us. If we need to adjudicate, they come to us. We obviously use Cited through the results portal that's provided. And I developed pro forma template letters. So 1 to 5, and there's a sort of lump number on the wall, and it literally saves the dictation. You just have to say, Jimmy Smith, capsule sponge letter C1. I'm pleased to tell you, your capsule sponge confirms Barrett's, but there's no evidence of dysplasia, and you'll receive a repeat appointment in X. So that actually streamlines the whole thing. As I say, we were very lucky that we actually had a way of dragging out all our Barrett's patients from our endoscopy waiting lists because of the way our electronic system is set up, and that might not be the same everywhere. I don't know if you find this at home, but in your base, but there's a sort of whack-a-mole element to Barrett's in that every couple of years I go through the Barrett's database and I weed out all the C0M1 gastric metaplasia only in 81-year-old ladies. And I say, these are not Barrett's, and you're not getting another endoscopy. And then they just keep reappearing. People just sneak them back in, to the system, or new ones keep appearing. And so there was a huge piece of work went on. And I guess I don't think I could ever do this again, but this was the early days of COVID. And there was a lot of sitting around at desks and being on Zoom and team meetings and not a lot of actual clinical activity. So I actually went through 1,500 so-called Barrett's referrals, trimmed that all down, and then used them to stratify are these people overdue? Are they short segment? Are they long segment? Are they in? Are they out? And a colleague helped me do this. And we moved everybody over to Capsule Sponge with a letter explaining that this was going to happen and why. Except people with previous dysplasia or people who'd previously done RFA, EMR for early neoplasia, previous stricture, concerns about Capsule making it through, or fundoplication, same reason. We opted to keep people out who had more than 10 centimeters of Barrett, ultra long Barrett's. And we obviously, if people phoned up and said, I don't fancy this sponge test, not for me, I want to stick with endoscopy, then we would try and rationalize or reason with them. But if they expressed a strong preference, then we would obviously accept that. If you're doing Capsule Sponge, this is the sort of report you get. Is the squamous cell clump sufficient and adequate numbers? Same for columnar. What's the TFF3 status as a marker of intestinal metaplasia? Is there aberrant P53 expression? Is there atypia? And there's usually a comment in the report about the likelihood or possibility of dysplasia being present. We developed a small table. This doesn't read very well. I had to sort of copy and paste it onto this navy blue background template slide here. But, what to do? What's the outcome? Yes, you have intestinal metaplasia, but no atypia, no P53, low risk of dysplastic Barrett. Continue with surveillance, but by sponge. If you have atypia or P53 or both, high risk group, urgent endoscopy. If you have atypia of uncertain significance, dysplasia is unlikely, but we put them straight into endoscopy as well. I'm not sure we've moved away from that. I think we're still following these people by endoscopy rather than by repeat Capsule Sponge, but I think that will change. And then the people who have no TFF3, no atypia, no P53, no evidence of Barrett, out they go, unless they've previously had evidence on endoscopy of intestinal metaplasia, and we keep them in. Siobhan Chen's paper, and one of the weaknesses of the Cytoscot Scotia project data is that obviously there are the unknown unknowns and all that kind of thing, because not everybody got an endoscopy, so you don't really know what the true outcome of these people is. But we, up until 2023, had done 4,000 tests in Scotland, not just Lothian. Of 608 had moved on to endoscopy because of a positive test, with about an 8% yield of high-grade dysplasia. Almost everybody with high-grade dysplasia was in the high-risk group. Actually, all of them, when you took out people who had an incomplete capsule or came back for a repeat capsule. We had no cancers presenting symptomatically in the first year post-capsule in the low risk group, and that now extends out to 3 years. We had one interval cancer following a negative capsule test, and we did an SAE on that, and we took it back to CyTED, and two pathologists looked at it again. This was a good sample, plenty of cells, perfectly adequate, still no atypia, still no P53. Just one that escaped through the net. But as I say, you have to bear that in the context of that also happens with endoscopic surveillance. We now do around 20 procedures a week. We detected approximately 20 early cancers so far, no symptomatic cancers. We offer sponge training as a career development option for Band 5 endoscopy nurses if they want to look at that. We think we've brought our waiting list down for endoscopy significantly. We now have a restricted number of Barrett surveillance slots. In fact, there are only 2 of us who do the Barrett surveillance, and we can kind of manage most of that. Because we can now corral that into lists done by people with an interest in Barrett's rather than sprinkling it like fairy dust all over everybody's lists. So to kind of basically sum it up, if I was a patient, and again, personal views here, I'd want to know I had Barrett's. So I'd be a fan of some kind of case finding or screening. I'd want that test to be cheap, simple, safe and done in primary care. I'd want to have some oversight by an expert in that condition. And I'd want to then be in surveillance, which was regular and reliably organised and accurate and well organised. And I want it to prevent me dying of invasive adenocarcinoma. If I was a specialist or a healthcare provider, I'd want to know who all my Barrett's patients are and have a system of recalling them. And I can't really go into details, but there are medical legal issues around this popping up, not infrequently, that people are taking legal action because no one either told them they had Barrett's or wrote them a letter telling them, the biopsies I took at your endoscopy done for reflux, just show a bit of Barrett's esophagus, chat, stay on your PPI, but never really explained the implications of the condition to them. Or they never got sent for and never got recalled. So if I was a healthcare provider, I'd want a surveillance program that had capacity and could deliver it in a timely way, was accurate and affordable, and prevented my patients from dying from invasive esophageal adenocarcinoma. This is Danielle Morris's data from the English study, similar to the one we did in Scotland from Cytoprime. It's a very acceptable test. It prevents a lot of procedures. And think about the green agenda and the amount of waste and carbon dioxide and water. How many, it's 30 odd degrees out there. How much water do we use cleaning one gastroscope? It's something like 70 to 100 litres cycling one scope. And add that up across your trusts and how many lists a week you do. And it's not insignificant. But here we are in 2026, and I thought Jim Mackey at the plenary session spoke really well. Everybody there spoke really well, highlighting the way forward. But the common theme going forward is finding less invasive ways, and making endoscopy a resource we use for a small group of people to make or confirm a diagnosis and to perform therapy. And everything else should be done in a blood test, sputum test, molecular profile way, or a non-invasive test, a minimally invasive test. And the funding, I have to tell you, is not going to get any easier. So demand will continue to outstrip capacity. Waiting lists will struggle to come down. Surveillance is not a government target, unlike cancer weights and that kind of thing. So your managers are only measured on 1 or 2 metrics: financial balance and bringing down waiting times. So what gets squeezed every single time? Surveillance. And you can bang your head against the wall saying, but these are high-risk people. If you want to prevent cancer, these are the people we should be focusing on. And they'll say, yes, I know, I get all of that, but I am being hammered by the director of finance and the chief exec. Workforce is a problem at the moment. Jim Mackey spoke very well about how we try and do that, but there isn't an overnight fix to that. We've got a struggling workforce. So I'm going to leave you with, normally what would happen is I open it up to questions and you grill me, but I'm actually going to leave it with a whole bunch of questions for you so that I can head out the fire exit. Is your trust or board, as we call them in Scotland, up to date with its Barrett surveillance? Do you have a standard operating procedure to ensure that you recall your Barrett's patients in a proper, timely manner? In the last 2 years, have you seen a patient at your upper GI MDT who presented with symptomatic adenocarcinoma despite being known to have Barrett's and being in a surveillance program? If you did, do you SAE this? Do you Datix this? Or does everybody just say, tough, you know? Do you know what your own trust Puget rate is? Have you ever measured it? And when you scope, do you ever see patients on your list for with Barrett's at the wrong intervals? Should have been done in 5 years because he had 2 centimeters, but here he is, 18 months after his last one. You know? These are just things we weren't up to date. We didn't have an SOP, but we kind of do now, thanks to Capsule sponge. Oops. Yes, every Friday I see symptomatic cancer. Not every Friday. We're not very good at Datixing that. I don't know what Lothian's Puget rate is, if I'm honest. And yeah, I see people at the wrong intervals all the time. So for all these reasons, I think Capsule sponge is a good way of dealing with all of these really quite knotty, difficult problems. And do you have a set of quality standards for your Barrett surveillance endoscopy? Do people use PRAG criteria? Do they document the length? Do they do 4-quadrant biopsies? Do they take adequate photographs? You know, do you have those or not? Now, I can't tell you what's going to be in the guidelines, but I think hopefully they'll address quite a lot of these issues. Thank you.
Thank you, Ian, for a very thoughtful talk. It was excellent. Right, we've got some questions coming through. Yes, there's a microphone on its way.
Thanks, Dr. Penman. That's a great, brilliant presentation. We're looking to do something similar in Greater Manchester. I'm Dr. Ratcliffe, I'm one of the gastroenterology consultants there. I have 2 questions. Hopefully I can get through them quickly. First of all, did the Lancet paper, in terms of risk stratification, change the way that you risk stratified patients into capsule sponge or endoscopy surveillance? And then the second question is, are you moving into using primary care to deliver the sponges, or still running it through your fellows and your nurses?
Yeah, I kind of take the second one first. So no, we still do it in secondary care. Could we do it in primary care? Yes. I think Edinburgh is no different than anywhere else in the UK. Our GPs are under the cosh and feeling really stressed. They have a million things to do, and we have good relationships with them, but anytime we ask them to take something on, even if we come with cash, it's difficult for them. And given that we're only doing about 20 a week, now that might be very, very different if we roll it out into screening high risk or case finding to find Barrett's. I think that would have to be done in primary care. But the actual Barrett surveillance, we're quite happy keeping it in-house in secondary care. Did the Lancet paper change? No, not yet, but it should. And I think we will. I think what I'm going to do is wait for the official launch of the guidance and use that as a way of changing our kind of SOP in Lothian to how we risk stratify. But I think we will keep the vast majority of our Barrett surveillance as capsule sponge going forward.
Ian, we've got a question from Paula Brayford in Shrewsbury on the app. Are your patients, Barrett's patients, under lots of different consultants, or are they under you or another interested consultant?
Yeah, good question. They are, well, because I'm elderly and I've been around a long time, they just gravitate to you. And so I probably have the largest cohort of Barrett's patients, but it's not a case of, well, this person's got Barrett's, refer him to Dr. Penman. Most people with Barrett's are discharged back to their GP, but they remain on our surveillance database and we call them back in. They're not actually under anybody. We don't see them in clinic on a annual basis or anything like that. I spent a long time, surgeons and colorectal surgeons and IBD specialists would come to me and saying, I'm not doing Barrett surveillance anymore. It's far too specialized and I shouldn't be doing it. And I used to say to them, well, look, it's a straight pipe. And you don't even have to get out your comfort zone and fall into the stomach. You just have to, if you can't put an endoscope down to 40 centimeters and look carefully, I don't think you should be doing endoscopy at all. But I have vault-fast decided that just didn't work, and it needs to be done by a smaller number of people who are really interested in it and will do it properly. Now, they couldn't cope with the volume, and the way to cope with the volume is to actually find a better, simpler way of dealing with most of it.
Question at the front?
You made a comment about patients not having information about what Barrett's was. Do you have information you send out? I noticed Guts UK has got a patient leaflet about Barrett's. Do you refer to that, or,
Yes.
or how do you approach that?
Yes, so when we confirm Barrett's, we have template letters, and so I don't want to turn this all into automatons, but you want people to be consistently told the same thing rather than Dr. X tells them one thing and Dr. Y tells them something completely different. So that was part of the standardization to reduce variation. It informs them that they've got Barrett's, that Barrett's is common, that Barrett's is usually harmless, but that in a small percentage is a significant risk factor for cancer, and the rationale for why surveillance is important. We were involved 10 years ago in a medical legal claim locally that a man who died of esophageal adenocarcinoma felt he hadn't been given adequate information, and when he got a letter through 3 years later saying pop back for another endoscopy, he didn't really realise why this was important, and he didn't respond to it, and he didn't turn up, and 2 years later he's got cancer. So we have structured information, but the Guts UK leaflet is very good, and we, to save paper, don't print it out, but it's the URL, the hyperlink for more information is here.
There was a question from the audience whether you'd share any of your results templates. Is that something that you would be?
Yes, I would. Yeah, absolutely. there's no preciousness about them. If you want to adopt them, if you want to adapt them, if you want to chuck them in the bin, no skin off my nose. Happily make these available to anyone who wants them.
Any other questions? Was there any resistance from anybody when you adopted this plan? Yeah, if so?
No, I think everybody was so busy running around with buckets, firefighting. And I don't want to say under cover of COVID-19 because it was all done above board, but there was almost nothing good came out of COVID-19. But there was a sense that this is a time for innovative and imaginative thinking. It is a time to actually stop dithering, make decisions. I mean, I've lived through, I don't know how many chief executives who've come into NHS Lothian, and they all start saying, I want the senior medical staff to feel empowered. I want them to be empowered to take decisions, and to take bold actions, and to turn this around. So you write a small S bar on something and they go, nah, I don't think so. It's a bit risky.
Yes.
And 10 years later, you haven't done anything. So I think there genuinely wasn't any resistance.
Yeah.
But I think that was because of the moment in time we were at.
Yeah.
I think if I was to start it now, there could well be a degree of resistance. Medics are by process small c conservative, aren't we? And cautious, careful people. That's why we're not venture capitalists. It's why we're doctors. You know.
And you think the updated surveillance guidance will be available for everybody to see soon?
Well, I think there are some hoops we have to go through with the BSG. The BSG, they are very sensible, but they want us to get this right. I think there will be significant changes in the recommendations we make. Some of them are quite bold, and internationally, leading, and I think BSG wants to make sure that this doesn't blow back on us, and I totally understand and respect that. I think that is there anybody in the room who was involved in the BOSS trial?
No, you're safe.
Right, good. Okay, see, I mean, we were in Aspect, we were one of the major centres in Aspect, and BOSS came along in the back of that, and I think it was a great idea at the time. But it was based on, it's now, what was 2009 BOSS started? So 16, 17 years ago. The goalposts have changed. We now, but the fact that BOSS achieved high-profile publication in high-profile journal, and people just look at the abstract and the graph showing Barrett surveillance waste of time. And that feeds into, unfortunately, an agenda for people who think Barrett's already have cognitive bias against it, and who may want to use the capacity and the funding we have that's limited for other things like bowel cancer screening. So, understandable. So, I can't remember what was the question.
It was about the challenges of awaiting the Barrett's.
Oh, so the new guidelines. So I think they'll come out soon. I hope they'll be well received. I think there's some pragmatism and common sense. Did you see the guidelines about follow-up of polyps in people of borderline fitness? I think we've adopted that sort of mechanism as well, and that's built in there. And there's a good bit in the guidelines about appropriateness of surveillance according to patient fitness.
Good. Yeah, about time too. Right, we're out of time, so I'd thank you very much indeed, Ian. That was a fantastic talk, and thank you for attending.